Hello, my name is Vivian Haggerty, and this presentation is called A Challenging Case of Twin Pregnancy with Complete Hydatidiform Mole and Normal Live Fetus. Complete hydatidiform mole with coexisting viable fetus, or CHMCF, is a rare obstetric entity with an incidence of 1 per 20 to 100,000 pregnancies. Carrying a complete molar pregnancy to term has inherent risks secondary to elevated human chorionic gonadotrophin, or HCG, levels. These include hyperemesis gravidarum, preeclampsia, thyrotoxicosis, and possible preterm delivery. In this case, we examine the hospital course and outcomes of a patient with CHMCF whose pregnancy is also complicated by systemic lupus erythematosus with nephritis. A 31-year-old African-American, gravida 1 para 0, with a past medical history of lupus, end-stage renal disease status post right kidney isograft, and hypertension secondary to pre-existing renal disease, presented to outpatient clinic for an initial prenatal visit at 8 weeks 4 days gestation by last menstrual period. A dating ultrasound showed a single viable intrauterine pregnancy with a complex focus adjacent to the gestational sac of unknown etiology. At 13 weeks and 4 days, an ultrasound showed a prominent intrauterine fundal heterogeneous hydropic-like area along with a viable intrauterine pregnancy. An MRI showed a fundal lesion with grape clusters consistent with a diagnosis of CHMCF. After extensive counseling, the patient declined termination of the pregnancy. Daily aspirin 81 milligrams PO was started. At 27 weeks 5 days, our patient was admitted for inpatient workup to rule out chronic hypertension exacerbation versus superimposed preeclampsia after her blood pressure was elevated above baseline at a clinic visit. Her blood pressures responded to IV antihypertensives. Her BP on admission was 160s over 70s to 90s, and her total 24-hour urine protein was 672 milligrams. She was also started on oral antihypertensives. Blood work on admission revealed hyperthyroidism with a TSH of under 0.005. She was subsequently started on methimazole. A multidisciplinary team of gynecologic oncology, maternal fetal medicine, transplant surgery, endocrinology, and nephrology follow the patient throughout her hospital stay. She completed antenatal corticosteroids in preparation for a preterm delivery. Inpatient management was recommended until delivery at 34 weeks by primary cesarean section or earlier for maternal fetal indications. After counseling with transplant surgeons and obstetricians, the patient desired sterilization at the time of delivery for optimal immunosuppressant medications in order to maximize isograft function. At 30 weeks 5 days, the patient had rising blood pressures over 160 over 110 that were unresponsive to IV antihypertensive medications. As a result, and without delay, the decision was made to proceed with delivery. Primary low transverse C-section with bilateral salpingectomy was performed with preparations for hysterectomy if needed. An infant weighing 1,559 grams with APGAR scores of 4 at 1 minute and 7 at 5 minutes was delivered. The twin B-sac with hydrops was delivered total en bloc with twin A placenta and sac. Estimated blood loss was 618 milliliters. Blood transfusion was not required. Magnesium was continued for 24 hours postpartum for seizure prophylaxis. Pathology confirmed complete molar pregnancy. Her postpartum course was uncomplicated and her blood pressures normalized to 120s over 60s. Beta HCG levels declined dramatically and will be monitored weekly until normalization. Her neonate continues to thrive in the NICU and is currently breathing on room air and tolerating oral feeds. Twin pregnancy with gestational trophoblastic disease and coexisting normal fetus is an exceedingly rare condition with limited safety data on outcomes for mother and baby. We report a case of MRI-diagnosed CHMCF further complicated by extensive maternal comorbidity with successful maternal and fetal outcomes. We hope to highlight the potential for a successful pregnancy with early admission for blood pressure control and meticulous monitoring of HCG levels, thyroid function, and renal function in the setting of CHMCF complicated by preeclampsia superimposed on existing renal disease. Inpatient workup of blood pressures elevated over the patient's baseline and close observation of renal function and immunosuppressants were essential to the success of this case.